My name is Angela Washington, and I've been a black nurse for 18 years. I've been called difficult, stubborn, and insubordinate more times than I can count. But I've never been called wrong. Until Dr. Richardson decided my attitude problem was more dangerous than his medical incompetence. He got me fired on a Tuesday. The patient died on a Wednesday. And by Thursday, everyone knew who the real problem was. This is the story of how standing up for what's right cost me my job, but saved countless lives. It's about a system that punishes nurses for caring too much and protects doctors who care too little. And it's about the price we pay when good people stay silent. My journey at St. Mary's Medical Centre began like most nursing careers, with hope, determination, and the naive belief that doing good work would be enough. I was wrong about that last part. St. Mary's Medical Centre sits in downtown Detroit, a 400-bed teaching hospital that serves one of the city's most vulnerable populations. When I started there 5 years ago, I was already a veteran nurse with 13 years of experience from 3 different hospitals. I'd seen good medicine and bad medicine, competent doctors and dangerous ones. What drew me to St. Mary's was their reputation for innovation and their stated commitment to patient advocacy. The hospital marketed itself as a place where nurses were valued partners in patient care, where experience and intuition were respected alongside medical degrees and protocols. For the first 4 years, that seemed true. I worked primarily in the cardiac unit, building relationships with patients and families while maintaining the kind of detailed, thorough approach to nursing that had earned me recognition at every hospital where I'd worked. I specialized in cardiac patients because heart disease was personal to me. My father had died from a massive heart attack when I was 16, partly due to delayed treatment and missed warning signs that a more attentive medical team might have caught. I became a cardiac nurse to be the advocate my father never had. Dr. James Richardson arrived at St. Mary's 2 years ago as the new chief of cardiology. Fresh from a prestigious residency at Johns Hopkins, he was young, confident, and carried himself with the casual arrogance that some medical schools seem to instill, along with clinical knowledge. From our first interaction, something felt off. During patient rounds, Dr. Richardson had a habit of dismissing nursing observations and rushing through evaluations. When I tried to discuss concerns about patients, he would listen with barely concealed impatience before making decisions that seemed to prioritize efficiency over thoroughness. "Nurse Washington," he said during one early encounter, "I appreciate your thoroughness, but sometimes experience can lead to overthinking. Medical decisions should be based on objective data, not nursing intuition." The way he said nursing intuition made it clear he considered it about as reliable as reading tea leaves. But it was his treatment of other staff that really concerned me. Dr. Richardson seemed to have particular difficulty accepting input from nurses who looked like me. Male nurses, older white nurses, and especially nurse practitioners were treated with reasonable respect. But young nurses, particularly young Black and Hispanic women, were often dismissed or spoken to in ways that made me uncomfortable. I started keeping mental notes, telling myself I was being oversensitive. After all, Dr. Richardson was technically competent. His patients generally recovered well, and challenging the new chief of cardiology based on personality conflicts seemed like a good way to create problems for myself. I should have trusted my instincts. The first serious incident occurred 6 months after Dr. Richardson's arrival. Mrs. Garcia, a 67-year-old diabetic, was admitted with chest pain and shortness of breath. Her symptoms and test results suggested the early stages of heart failure, but Dr. Richardson diagnosed anxiety and ordered her discharged with anti-anxiety medication. I'd seen enough cardiac patients to recognize the subtle signs he was missing. Mrs. Garcia's breathing pattern, the slight swelling in her ankles, the way she described her chest discomfort. Everything pointed to a cardiac event, not anxiety. "Doctor," I approached him after reviewing her chart, "I'm concerned about Mrs. Garcia's discharge. Her presentation is consistent with early heart failure, and her history of diabetes puts her at high risk." "Nurse Washington," he interrupted, not looking up from his computer. "Mrs. Garcia's EKG is normal, her cardiac enzymes are within range, and her chest X-ray shows clear lungs. These are objective measures, not subjective nursing observations. But her symptoms and presentation are being properly evaluated by a trained cardiologist." His tone carried a finality that discouraged further discussion. Mrs. Garcia was discharged that afternoon. She returned by ambulance 8 hours later in acute heart failure, requiring immediate intervention that likely could have been avoided with proper initial treatment. When I mentioned the connection to Dr. Richardson the next day, he shrugged. "Heart failure can develop rapidly. There's no way we could have predicted this based on her initial presentation." But I knew better. And more importantly, I began documenting everything. Over the following months, a disturbing pattern became clear. Dr. Richardson consistently dismissed concerns raised by nursing staff, particularly concerns from nurses of colour. When those concerns proved valid, which they did with alarming frequency, he refused to acknowledge any connection to his initial assessments. Maria Santos, a young Hispanic nurse with excellent clinical skills, tried multiple times to discuss irregularities in patients' medications. Dr. Richardson would listen impatiently before explaining why her concerns were unfounded. 3 medication errors that Maria had identified early were later caught by pharmacy reviews, preventing potential complications. Jennifer Chen, an Asian American nurse practitioner with a master's degree, found her patient assessments routinely second-guessed and her treatment recommendations ignored. When those recommendations later proved correct, Dr. Richardson would claim the credit for monitoring the situation closely. But the most troubling pattern involved patient advocacy. When nurses raised concerns about patient safety, pain management, or discharge planning, Dr. Richardson treated it as insubordination rather than professional collaboration. "These nurses think they know better than doctors," I overheard him complaining to Dr. Mitchell, another cardiologist, "especially the assertive ones. They seem to think nursing school qualified them to practice medicine." I started keeping detailed records of these interactions in a secure notebook I kept at home. Dates, times, patients involved, witnesses present. I told myself I was just being thorough, but deep down I knew I was building a case for something I hoped would never happen. The case that ended my career at St. Mary's began on a Monday morning with the admission of Harold Thompson, a 72-year-old retired auto worker with a history of heart disease. Mr. Thompson was admitted with chest pain, elevated blood pressure, and what his family described as not acting like himself over the weekend. I was assigned as his primary nurse, and during my initial assessment, several things concerned me. His blood pressure was dangerously high despite medication. His heart rhythm showed irregularities that weren't documented in his previous records. And most alarming, his mental status seemed subtly altered. Mr. Thompson was oriented and conversational, but his wife of 50 years noticed changes that might not be obvious to medical staff who didn't know him. "He's been confused about dates," she explained privately. "And yesterday he couldn't remember our grandson's name. That's not like Harold." These subtle cognitive changes, combined with his cardiac symptoms and blood pressure issues, suggested a possible connection between his heart problems and reduced blood flow to his brain. It was the kind of complex presentation that required careful evaluation and monitoring. Dr. Richardson examined Mr. Thompson during morning rounds, spending perhaps 5 minutes reviewing his chart and listening to his heart and lungs. His assessment was straightforward: adjust blood pressure medication, continue cardiac monitoring, and plan for discharge in 24 to 48 hours. "Doctor," I approached him after rounds, "I'm concerned about Mr. Thompson's cognitive status. His wife reports memory issues and confusion that started around the same time as his cardiac symptoms. Could we consider—" "Nurse Washington," Dr. Richardson interrupted with barely concealed annoyance. "Mr. Thompson is alert and oriented. His cardiac enzymes are normal, his EKG shows expected changes for his age, and his symptoms are responding to treatment. Let's not create problems where none exist." But subtle cognitive changes can indicate many things, most of which are outside the scope of nursing assessment. His voice carried a warning that I recognized from previous encounters. "Please focus on your nursing responsibilities and let me handle the medical evaluation." That afternoon, Mr. Thompson's condition subtly worsened. His blood pressure remained elevated despite increased medication, and I noticed small changes in his speech patterns and response times that worried me. When I mentioned these observations to Dr. Richardson during his evening rounds, his response was swift and decisive. "Nurse Washington, I need to speak with you privately." Dr. Richardson led me to an empty patient room where he closed the door and turned to face me with obvious frustration. "Angela, we need to discuss your behavior. Over the past several months, you've consistently questioned my medical judgments, second-guessed my treatment plans, and created unnecessary anxiety among patients and families with your concerns." "Doctor, I'm just trying to advocate for patients based on my observations." "No, you're trying to practice medicine without a license." His voice was sharp, professional courtesy replaced by barely controlled anger. "I've been patient with your assertiveness, but this pattern of insubordination needs to stop." Insubordination? The word hit me like a physical blow. I'm raising legitimate nursing concerns about patient safety. You're questioning the medical judgment of a board-certified cardiologist based on subjective nursing impressions. That's not patient advocacy, it's professional overreach. I took a deep breath, trying to maintain my professionalism despite the clear racial and gender dynamics underlying this conversation. "Dr. Richardson, I've been a cardiac nurse for 18 years. I've seen thousands of patients, and I've learned to recognize subtle signs that can indicate serious problems. When I raise concerns, it's because you think you know better than the doctors." He stepped closer, using his height and position to intimidate me in a way that would never happen with a male colleague. "Let me be very clear, Angela. Your job is to follow medical orders, not to diagnose patients or determine treatment plans. If you can't accept that professional boundary, perhaps you should consider whether cardiac nursing is the right fit for you." The threat was unmistakable. Comply or face consequences. "I understand your position, doctor, but if I see something that concerns me about a patient's safety, I have a professional and ethical obligation to speak up." Dr. Richardson's expression hardened. "Your obligation is to follow the orders of the attending physician. Mr. Thompson is stable, his treatment plan is appropriate, and your continued interference is disruptive to patient care." He paused, letting his words sink in before delivering what felt like an ultimatum. "I'm documenting this conversation as a formal counseling session regarding insubordination and failure to follow proper protocols. Any further instances of this behavior will result in disciplinary action up to and including termination. Are we clear? I nodded, not trusting my voice to remain professional. Good. Please return to your duties and focus on nursing tasks rather than medical decision-making. That night I went home and sat at my kitchen table with my notebook full of documented incidents. 18 years of nursing, dozens of patients whose lives I'd helped save by catching things others missed. And now I was being threatened with termination for doing exactly what my training and experience had taught me to do. I thought about my father, who died because medical staff dismissed early warning signs as anxiety. I thought about Mrs. Garcia, whose heart failure could have been prevented with better initial assessment. I thought about Mr. Thompson, whose subtle cognitive changes were being ignored despite their potential connection to his cardiac issues. And I made a decision that would cost me my job but save my integrity. The next morning, I arrived early to check on Mr. Thompson. His condition had deteriorated overnight. Blood pressure still elevated, new irregularities in his heart rhythm, and according to his wife, increased confusion and disorientation. Doctor, I approached Dr. Richardson during morning rounds. Mr. Thompson's condition has worsened overnight. His blood pressure is not responding to medication, his cardiac monitor shows new arrhythmias, and his cognitive status has clearly declined. I think we need to consider the possibility of Nurse Washington. His voice was ice cold. Step aside. Dr. Richardson examined Mr. Thompson briefly, reviewed his overnight vitals, and made a note in his chart. Mr. Thompson is showing expected response to treatment, will continue current medications and plan for discharge this afternoon. I stared at him in disbelief. Everything about Mr. Thompson's presentation screamed that he was getting worse, not better. His wife was clearly frightened by the changes she was seeing, and his vital signs supported her concerns. Doctor, I can't in good conscience follow discharge orders for a patient whose condition is deteriorating. The words hung in the air between us like a challenge. Other nurses in the area stopped their activities, sensing the confrontation developing. What did you say? Dr. Richardson's voice was dangerously quiet. I said I cannot discharge a patient whose condition is clearly worsening. It would be unsafe and potentially life-threatening. Dr. Richardson pulled out his phone and made a call. Security to the cardiac unit, please. We have a situation. Within 15 minutes, I was sitting in the office of Helen Morrison, Director of Nursing, with Dr. Richardson, the Chief Medical Officer, and a representative from Human Resources. Angela, Helen began, her voice carrying disappointment rather than anger. Dr. Richardson has reported that you directly refused to follow medical orders and created a disruptive scene in front of patients and families. That's not what happened, I replied calmly. I expressed professional concerns about patient safety and indicated that I couldn't ethically participate in what I believed to be unsafe patient care. Dr. Richardson leaned forward. Nurse Washington has shown a pattern of insubordination over several months. She consistently questions medical judgments, refuses to follow established protocols, and today she directly refused to carry out physician orders. What were the specific orders? Helen asked. Discharge planning for Mr. Thompson, who is medically stable and ready for home care. I pulled out my notebook. Mr. Thompson has shown deteriorating vital signs, new cardiac arrhythmias, and progressive cognitive decline over the past 24 hours. His wife reports significant changes in his mental status that began with his cardiac symptoms. These signs could indicate many things, the Chief Medical Officer interrupted. But medical assessment and diagnosis are not within the scope of nursing practice. Patient advocacy and safety concerns are absolutely within the scope of nursing practice, I replied firmly. The HR representative consulted her files. Angela, your personnel record shows previous counselling sessions regarding questioning physician orders and… She paused, reading directly from the file. Failure to maintain appropriate professional boundaries with medical staff. I realised that Dr. Richardson had been building a documentation trail for months, preparing for exactly this moment. Helen, I addressed the nursing director directly, in 18 years of nursing, I've never had a patient safety incident, never had a medication error, and never failed to advocate for appropriate patient care. My concerns about Mr. Thompson are based on objective observations and clinical experience. Helen looked uncomfortable, caught between supporting her nurse and challenging a powerful physician. Angela, while your clinical skills are excellent, the medical staff has raised concerns about your collaborative approach. My collaborative approach, your willingness to work within the established hierarchy and follow medical direction without… She searched for the right words. Excessive questioning. The euphemisms were flying thick and fast, but the message was clear. I was being fired for being an uppity black nurse who didn't know her place. I'm afraid we have to terminate your employment effective immediately, Helen continued. You'll be escorted from the building and your access will be revoked. We'll mail your final paycheck and information about continuing your health insurance. Security was already waiting outside the office. I cleaned out my locker while a security guard watched, surrounded by colleagues who offered sympathetic looks but careful silence. No one wanted to be associated with the nurse who'd been fired for insubordination. As I walked through the parking lot carrying my personal items, I thought about Mr. Thompson. Who would advocate for him now? Who would notice if his condition continued to deteriorate? I got my answer the next morning when my phone rang. It was Maria Santos, the Hispanic nurse who'd tried to support me. Angela, her voice was shaking. Mr. Thompson died last night. The room seemed to spin around me. What happened? He was discharged yesterday afternoon, just like Dr. Richardson planned. His wife took him home, but around midnight he became confused and agitated. She called 911, but by the time they got him back to the hospital, he'd had a massive stroke. A stroke? Exactly what I'd been afraid of. The cognitive changes, the blood pressure issues, the cardiac arrhythmias, all signs that his cardiovascular system was failing to maintain adequate circulation to his brain. Maria, I need you to document everything about his case. Times, conversations, medical decisions, everything. I already am. And Angela, there's something else. Dr. Richardson told the family that Mr. Thompson's stroke was unpredictable and couldn't have been prevented. But I was there when you raised concerns about his cognitive status. That afternoon, I received a call from Harold Thompson's daughter, Linda. Through her grief, she asked the question I'd been dreading. Could my father's death have been prevented? I chose honesty over legal protection. Mrs. Thompson, I believe your father was showing signs of cardiovascular compromise that weren't properly evaluated. I tried to raise concerns about his condition, but those concerns weren't addressed. What kind of concerns? I explained about the cognitive changes, the blood pressure issues, the subtle signs that could indicate reduced blood flow to the brain. I told her about my conversations with Dr. Richardson and the dismissal of nursing observations. So you're saying someone could have prevented this? I'm saying that more thorough evaluation and monitoring might have caught the problem before it became fatal. Linda Thompson was quiet for a long moment. My father always said that nurses were the ones who really took care of patients. He said doctors make the big decisions, but nurses notice the small things that can save your life. Your father was a wise man. Can you help us understand what really happened? Linda Thompson hired a medical malpractice attorney who specialized in hospital negligence cases. When they requested Mr. Thompson's complete medical records, the hospital's defensive response told us everything we needed to know. The attorney, David Chen, no relation to nurse Jennifer Chen, was a former emergency room physician who'd left medicine for law after witnessing too many preventable patient deaths. "Angela," he said during our first meeting, "what you're describing is a pattern of dismissing nursing concerns that could constitute negligent patient care. But proving it will require documentation and witness testimony." I handed him my notebook. Months of documented incidents, dates, times, witnesses, patient outcomes. David's eyebrows rose as he flipped through the detailed records. "You documented all of this while you were employed there?" "I learned a long time ago that in nursing, especially as a black woman, you have to protect yourself with documentation. Too many times our concerns get dismissed, and then when something goes wrong, we're the ones blamed for not speaking up loudly enough." David's investigation revealed that I wasn't the only nurse who'd been documenting problems with Dr. Richardson's patient care. Maria Santos had kept her own records of medication errors and misdiagnoses. Jennifer Chen had documented instances where her assessments were ignored, leading to delayed treatment. But the most damaging evidence came from an unexpected source. Dr. Patricia Williams, the hospital's only black cardiologist, had been quietly documenting her own concerns about Dr. Richardson's patient care and his treatment of nursing staff. As a physician, her observations carried the kind of weight that nursing concerns didn't. "I've been watching this situation develop for months," Dr. Williams told David during a deposition. "Dr. Richardson has consistently dismissed input from experienced nurses, particularly nurses of color. When those nurses' concerns later prove valid, he refuses to acknowledge any connection to his initial assessments." The medical review of Mr. Thompson's case was devastating to the hospital's defense. 3 independent cardiologists concluded that his symptoms clearly indicated cardiovascular compromise affecting cerebral circulation, that appropriate monitoring and intervention could likely have prevented his stroke, and that the nursing concerns documented in his chart should have triggered more aggressive evaluation. The lawsuit made local news, but the real story emerged when the State Medical Board launched their own investigation into patient care practices at St. Mary's Medical Centre. What they found was a systemic pattern of dismissing nursing concerns, particularly concerns raised by nurses of colour. Patient outcomes data showed higher rates of complications and readmissions for patients whose nurses had documented safety concerns that were subsequently ignored. Dr. Richardson's medical license was suspended pending a full review of his cases. The hospital faced federal civil rights violations for creating a hostile work environment that discriminated against nursing staff based on race and gender. But the most satisfying moment came when I testified before the State Nursing Board about the professional and ethical obligations of nurses to advocate for patient safety, even when that advocacy conflicts with physician orders. "Nursing is not a subordinate profession," I told the board. "We are licensed healthcare professionals with our own scope of practice and our own ethical obligations. When we see something that could harm a patient, we have a duty to speak up, regardless of who disagrees with us." The Nursing Board's ruling was groundbreaking. They established clear guidelines protecting nurses who raise patient safety concerns from retaliation, and they mandated training for all healthcare facilities on the professional role of nursing in patient advocacy. 6 months after Mr. Thompson's death, I received a call from Helen Morrison, the Director of Nursing at St. Mary's. "Angela, I want to offer you your job back with a promotion to charge nurse and a significant salary increase. We've implemented new policies protecting nurse advocacy, and we want experienced nurses like you to help us rebuild our patient safety culture. I appreciated the offer, but I'd already accepted a position as Director of Nursing Excellence at Detroit General Hospital, where my job was specifically to ensure that nursing concerns were heard and addressed at the highest levels of hospital administration. 5 years later, I speak regularly at nursing conferences about patient advocacy and professional courage. The Thompson case, as it's become known in medical ethics circles, is now taught in nursing schools as an example of how professional obligations can conflict with institutional hierarchies. Mr. Thompson's death was tragic and preventable, but his daughter Linda has become a powerful advocate for patient safety, working with nursing organisations to ensure that nurses' voices are heard and respected in healthcare settings. Dr. Richardson eventually left medicine and now works in pharmaceutical sales. Dr. Patricia Williams was promoted to Chief of Cardiology at St. Mary's and has implemented policies ensuring that nursing assessments are given appropriate weight in patient care decisions. The most important lesson I learned wasn't about standing up to doctors or fighting discrimination, though both are sometimes necessary. It was about understanding that my value as a nurse comes not from avoiding conflict, but from embracing the responsibility to speak for patients who can't speak for themselves. Being fired for insubordination was the hardest thing that ever happened to me professionally. It was also the most important, because sometimes the only way to save lives is to risk everything you've worked for. Harold Thompson died because his symptoms were dismissed and his nurses' concerns were ignored. But his death sparked changes that have protected countless other patients whose nurses now feel empowered to speak up when something seems wrong. I still think about Mr. Thompson and his wife of 50 years, who noticed changes that medical staff missed because they didn't know him well enough to see the subtle differences. I think about Linda Thompson, who trusted me with her grief and her questions about preventable death. And I remember what my father always told me. Sometimes doing the right thing costs you everything, but not doing the right thing costs you even more. In nursing, we see people at their most vulnerable moments. We notice the small changes that can signal big problems. We advocate for those who can't advocate for themselves. That's not insubordination, that's our job. And some jobs are worth getting fired for.